Thank you very much for the kind introduction, and thanks for the organizing committee and Tamer for inviting me today to talk about the paradigm shift in application of intravenous iron in different settings. We try today to give you a focus in patient interest or patient-centered approach, and I will start with to show you how globally iron deficiency anemia is affecting every continent. And you can see here from the darker dark red color that severe iron deficiency, and lighter color is moderate iron deficiency, and prevalence more in Southeast Asia, Africa, and South America. And of interest, of course, in Middle East, you can see Saudi here, fortunately enough, only moderate iron deficiency, and other countries severe. To show you how important to address iron deficiency, it affects actually 2 billion people worldwide. And as the WHO said, year lived with disabilities, they found 36 or more than 1/3 of these years lived with disability is due to fact of iron deficiency anemia. Of course, the more disadvantage for developing countries and can constitute a health crisis and economic consequences if this problem not addressed in the proper way. You can see here in this graph data gathered by the WHO from 188 countries during 90 years to 2013. And you can see here that women are most vulnerable among patients with iron deficiency, and men is less likely, and the iron deficiency constitute 60% of these patients among all other diseases. If you look here, pregnant women in particular, you can find that women in childbearing potential have about 30% prevalence of iron deficiency, and this jumps in 42% in pregnant women due to the increased demand, and compared to men and elderly, this is much higher rate of iron deficiency. If we look at the recommendation how we treat iron deficiency in setting after pregnancy and postpartum, in particular when women loses significant amount of blood during birth, we found that many countries in Europe and Asia Pacific utilize proactive treatment. If the hemoglobin drops below 9.5 gram per deciliter, they start to commence intravenous iron. And Germany has less conservative management with if the hemoglobin below 8 or 12 ferritin per milliliter. And also Asia Pacific, they have active rule in giving intravenous iron in patients who drops the hemoglobin below 9.5. In Australia, we use 11 the marker if the patients did not respond to oral iron. In UK, they watch the patients if they do not absorb oral iron or have any issue with efficiency of the therapy, they switch to intravenous iron. This is the UK guidelines recommend the intravenous iron, as we say, if the patient have iron deficiency anemia and a trial of oral iron was unsuccessful for at least 2 weeks, they commence intravenous iron as the most appropriate way to replace total iron body requirement. So to jump to another topic, and anemia in cancer, and you can see here in this graph that clearly that solid tumors and hematological malignancy are associated with iron deficiency anemia for different reasons. And if you look at the pathophysiology, you found that blood loss could be either due to surgical event to remove the tumor, or due to the blood loss in gastrointestinal tumor or urogenital cancers where blood loss is imminent. And sometimes cancer cachexia also can be imminent in case of malnutrition, of course, and associated with cancer. And another contributing factor, which is very important, that immune inflammation can, of course, make the hepcidin level, which is a peptide produced by the liver, and upregulate the iron as high as it could be, and block the absorption from the duodenal cells of the iron, and hence create what is a status called the functional iron deficiency. And the functional iron deficiency, of course, no matter you give oral iron, wouldn't work because of lack of absorption. And the only way to overcome the hepcidin blockade to commence intravenous iron. Of course, kidney disease can play a factor in cancer patients, either primary or secondary, and use of erythropoietin here is important. And lastly, the bone marrow, either primary disorder due to the leukemia or lymphoma, or secondary due to the bone marrow metastasis, or due to chemotherapy or radiation therapy, can affect the production of erythropoiesis and cause also lack of iron. And the major question now, why we use intravenous iron over oral iron? And the simple answer is most of the iron preparation, iron sulfate, is not really readily absorbable by the gut, and at the same time causes about 70% side effects for the patients and makes a lack of compliance. So it is totally ineffective therapy, and especially if it is co-administered with antacid or say a lot of tea or certain amount of food can block the absorption of iron. Adding to that, if as we say, if the hepcidin increases and blocks the absorption of iron, hence can be an issue to administer or ingest oral iron without any efficacy. There was a few consideration of safety in oral iron and intravenous iron, especially intravenous iron in first generation. But now, with the third generation, we got very few adverse events, and I will go through it very thoroughly. So the short-term hypersensitivity reaction, fortunately enough, mostly mild, self-limited, and mainly due to the labile iron, which is react to non-transferrin bound iron and causing this problem. Also, hypophosphatemia can occur in short and longer term, and I will explain that later. So there is a multiple randomized control trial, and I will mention all of these trials in later slides, and 401 in nephro and generalized iron deficiency anemia, and also phosphor IDA trial and IBD trial, which both showed that hypophosphatemia occurs significantly with certain product like Fer-Inject compared to Monofer, with significant increase of hypophosphatemia in case of Fer-Inject. Why ferric derissomaltose or Monofer, as we call it, is molecule is different from others, is because it have a strong iron matrix compound with a carbohydrate, and hence the release of iron is very slow and controlled, and it can take a longer time, and hence the labile iron or free iron or non-bind iron is very small amount, hence doesn't cause much adverse events. And this unique molecule, if you give it as a single infusion, you don't need to repeat it, and most of this study, if you give it 20 milligram per kilogram body weight, as indicated, 3/4 of the patient require only a single infusion, 1/4 require the second one, while if you look at other products like Ferinject, 1/3 require one infusion and 2/3 multiple infusions. The immediate and short adverse reaction is very important to educate our nurses, to show them how to deal with the patient, assure the patient, because half of this work done by experienced nurses in our facilities in Australia. And you can see here that fish pain reaction, which is can be common, and patients stop the infusion and they don't like to continue. However, if we assure them this is a very mild reaction, and once you give the infusion very slowly at the beginning, unlikely to happen. And once it happens, you just stop, of course, the infusion, assure the patient, offer something to drink, and so on. And then you can resume the infusion without any side effects. But however, fish pain reaction or the flushing symptoms is common but self-limited and needs assurance for the patients, and it doesn't occur with any vital signs changes like hypotension, lack of oxygen saturation, or tachycardia. However, anaphylaxis, of course, is possible, can occur. This can change the vital signs and has to be addressed appropriately, and cardiovascular resuscitation should occur. A few days later can also a flu-like symptoms, the bone aches occurs, and I keep telling my patients this is the signs that the iron working, because this is the bone marrow start to produce new red cells. Panadol, or again, it's self-limited side effects, and paracetamol can be very efficient in these cases. However, we found assurance of the patient education, experienced nurses is a very important rule, even to put the cannula in the right position without putting in a joint that can cause extravasation is very important. Withdraw blood, to flush with saline, to make sure that there is no obstacles is very important too. So the low phosphate can happen later on after 1 week of the infusion, and I will talk about that in details. So this is a complex diagram. I don't expect you can see all of that. However, it is just in brief, as we said earlier, if the immediate reaction occurs and we have to stop the infusion and reevaluate the patients. And if it is a fish pain reaction, you can re-challenge after a pause, and of course the patient settled and with a very slow rate. And if it is isolated symptoms, urticaria or itching, you can use antihistamine. And of course, if it is symptoms indicative for anaphylaxis or something like that, we can't re-challenge, and we have to, of course, to apply the measurements you have in your institution. And you can see in the picture here how the fish pain reaction and redness of the skin occurs. Here is in this slide to show you how rare is serious hypersensitivity reaction with third generation intravenous iron. We looked at about 8,600 patients. Most of them received iron isomaltoside or monofer, and then 1,800 received ferric carboxymaltose and iron sucrose, 2,700 patients. And we found that hypersensitivity reaction, it is all around 1% mark, was the lowest in monofer group, and a ferri inject 1.4, and iron sucrose 1.1. So the adverse events is rare and with new iron preparations. If you look at here the monofer total dose infusion, the result is actually fewer adverse events. And you can see in the graph in the blue here that the monofer single infusion much lower adverse events than multiple infusion with iron sucrose. The important trial, as we said, to manage randomized control trial for iron deficiency anemia, the 401 program analyzed about 3,000 patients, and we give here 1,000 milligram, a single dose of monofer versus multiple doses of iron sucrose, and we found that safety and efficacy endpoint showing clearly that in the left that patient hemoglobin improved with monofer group, and if you look at the middle graph, this is the ferritin has a sharp increase with the monofer and was superior than the iron sucrose group. And the last graph is iron saturation or ferritin saturation. Also, transferrin saturation increased significantly with the monofer group versus the iron sucrose group. The phosphor IDA trial to look at the hypophosphatemia, which is a very important part I wish to attract your attention to, that even FDA issued a label change in this regard with ferri inject. In this case, we have a monofer single infusion versus tandem ferric carboxymaltose infusions, and we looked at patients here at all points. You can see that hypophosphatemia occurred up to 75% in ferric carboxymaltose group versus less than 5% in monofer group. And if you look at day 7 and day 8 and maximum at day 14, the hypophosphatemia occurred in 70% of the patients in ferric carboxymaltose, and is still less than 5% in monofer group or ferric isomaltoside. So in summary here, you can see that even not only the hypophosphatemia matter, but also the fatigue scale is affected with, if you see the blue line in the left graph, that the patient with greatest decrease in phosphate have the lowest improvement in the fatigue scale, and vice versa. And this is clearly associated with ferric carboxymaltose group, while the hemoglobin response by decrease in phosphate did not change significantly. To talk about regulation of phosphate metabolism or homeostasis, we have a very important player or growth factor, which is fibroblast growth factor family 23, and it helps in urinary excretion of phosphate. And you get the parathyroid gland, which regulates the vitamin D as well as calcium and urinary excretion of phosphate. And you can see that ferri inject can increase the F23 and increase the urinary excretion of phosphate, and hence cause of hypophosphatemia. If you look at the signs and symptoms of anemia, we can overlap, of course, with hypophosphatemia. They share the weakness, fatigue, and tiredness. However, if you look at short term, the bone pain start to occur, and the longer term, the osteomalacia, of course, and pseudofracture can be devastating. So because of importance of hypophosphatemia, the cancer National Comprehensive Cancer Network issued a warning that whenever you utilize ferric carboxymaltose, you have to increase the awareness of and complication of hypophosphatemia and to monitor the phosphate level regularly. This is a case study published in Gastroenterology in 2017 and showing perfectly normal pelvic bones and femur and head of the femur in particular. The patient has severe groin pain and waddling gait, and he has a background of Crohn's disease and received about more than 20 infusion of ferric inject. If you look at the MRI scan, which couldn't demonstrate in the X-ray, there is a hyper intense focus in the neck of the femur, indicating why the patient has the pain and liable to fracture, and treated, of course, with internal fixation, and this caused later on stress fracture because the bone was osteoporotic. If you look at this particular case, you can find that 27 grams of ferric carboxymaltose infused, and also that hypophosphatemia was very evident while infused with carboxymaltose, and hence caused the osteomalacia and through the FGF23 pathway. So to this point, the ferric carboxymaltose-induced hypophosphatemia getting attention, and all regulatory authorities in Europe, in US issued warning or alert to the all users, and even in Saudi and Japan and Korea as well. If we look at the latest issue from Denmark and DFA as well, and Hong Kong, alerting that there is a bone risk, serious outcome, including osteomalacia, fracture can occur, and as well as symptomatic hypophosphatemia being reported after even one dose, and there is a clearer guidance on monitoring and treatment. So this is something we have to be alerted to. The risk factors for hypophosphatemia here in all authorities labeled as history of gastrointestinal disorders, vitamin D deficiency, inflammatory bowel disease, and also hyperparathyroidism. And all of these conditions should be monitored for hypophosphatemia and osteomalacia, especially if we're using ferric carboxymaltose, which is known to cause hypophosphatemia as compared to other molecules of iron. So to this point, I wish to share with you that we are in Australia. We have monofer or iron isomaltoside labeled in 2019, and ever since we used it in our facility with about 4 hospitals, 5,000 patients received the infusions, and without major adverse events, and the average hemoglobin increased by 2 grams after the infusion, and the average ferritin was 200 microgram also compared to before the treatment. And this increase in hemoglobin and the ferritin levels are highly significant. The treatment in general was well tolerated without serious side effects. There is some fish pain reactions occurred which self-limited and required no treatment, and about 15% received the higher dose, which is about 1,500 milligram in a single infusion, and this also well tolerated and given over longer period of time, 30 minutes. In summary, and to wrap up my talk, Anemia has been recognized, as you know, as an independent risk factor and predictor for poor prognosis, not only in cancer patients, but also in women with childbearing potential, pregnant women, other diseases like IBD, chronic kidney disease, perioperative anemia, and it is important in cancer patients. Like a study assessed 60 different trials with survival and risk of mortality in cancer patients, found that 65% with overall increase of mortality and with anemia compared to those without anemia. So it can has effect not only in quality of life but also survival as well. The impact of anemia and hypophosphatemia should really be alerted and highlighted, and especially when it affects the overall outcome and survival. It can delay treatment, of course, and can have devastating consequences. Addressing all of issues with hypophosphatemia is a key goal or ultimate goal for better outcomes, to avoid any complications with osteomalacia. And finally, addressing anemia in different settings, very importantly, to apply also intravenous iron, and can improve overall outcome and survival as well as quality of life for patients. Thanks for your attention, and happy to take any questions. This is where I work.